Thank you very much, Dr. Carlos. That was a very informative presentation. I'm sure our doctors, our experts from HCG, they have some questions about the technology. So if there's any, I think he can have a free communication now.
Yes, Dr. Carlos, congratulations and thank you so much for an excellent presentation showing us the microwave ablation for thyroid. There are a few questions. The first one which comes to my mind is that when you say that you do it for benign nodules, what is your method of diagnosis? Are we taking only Bethesda 2 nodules for this, or we also take Bethesda 3 and 4 also as benign?
No, nowadays we are performing only for benign nodules. The traditional protocols required 2 fine-needle aspirations with benign cytology. But if you have only one cytology, showing Bethesda 2, for example, and a very, very, how can I say, good aspect of the nodule, it's a spongiform nodule with no doubts in the ultrasound, you can perform with only one fine needle aspiration and benign cytology. But most of protocols require 2 nowadays. For Bethesda 3 and 4, there are no evidence in the literature showing us that this procedure is safe. Why? Because you may be dealing with follicular tumors that have another kind of behavior. Sorry? The screen. Then the papillary carcinoma. And for malignant disease, we are starting our protocol. We wait for some skills and knowledge about the technique, and we will start in the second semester of this year doing this technique for microcarcinomas, less than 1 centimeter, in good positions, not so close to the trachea, not so close to the posterior board of the thyroid glands, because in the carcinomas you need to perform a slightly different technique. You need to ablate not only the nodule, but the surrounding tissue. And you, in most cases, need to perform the hydrodissection to protect the structures that are adjacent to the nodule. And summarizing, for Bethesda 3 and 4, there are many discussions. I think in the next year, maybe some authors are starting to doing it, mainly based the decision in genetic tests, for example. The MIR type and other tests can select the nodules to be treated as benign ones. But you have to take in mind, I don't know in India, but here in Brazil, this costs a lot. A genetic test costs as much as a microwave antenna. And then I prefer to continue operate the Bethesda 3 and 4 cases and to ablate the Bethesda 2 nodules to be more safe.
Yeah, here cost is a constraint also, and the genetic testing, the Afirma or Thyroid cost a lot compared to the surgery. So most of the time, these tests are not done. And most of the Bethesda 3 and 4 would go for surgery. So as I understand, this technique right now is indicated for benign nodules, Bethesda 2, and favorable micropapillary carcinomas, right?
Yes, and for autonomous nodules too, for plumber disease, for example. It's a very good option.
And what is the largest size of the benign nodule which can undergo this?
Well, as Dr. Spiezza, that was in our course 2 weeks ago, Dr. Spiezza is from Napoli. We learned ablation techniques with him in 2018. There is no limit. There is no upper limit. The limits are the characteristics of the patient and the position of the node. For example, the largest one I have ablated, it's 107 cubic centimeters. It's a node with 10 centimeters by 6 centimeters by 4 centimeters. In 1 month, we had 50% of the reduction of this node with no complications. It was a longer procedure. It take us more than 20 minutes to ablate all this nodule with more sedation, because the patient starts to feeling the swelling, and sometimes the heat when you are closing the superficial structures. But after 1 month, 50% of the reduction of 100 cubic centimeters, I think it's a very, very good result. The limit is the anatomic limits. For example, if you have a goiter that's going through the mediastinum and the patient have no conditions of surgery because of cardiac conditions or pulmonary conditions, you can do this too, ablating the part of the nodule that is visible in the neck. And then with the time, the shrinkage of the tissue will pull up the thoracic part of the goiter, and then you can perform another section. But for these larger nodules, larger than 60, 70 cubic centimeters, you can warn the patient that maybe he will need another session of ablation after the 3rd or the 6th month. The point of to decide this is the 6th month. If you do not achieve 50% of reduction after 6 months, you need to ablate again, or to leave the nodule as if the patient have no symptoms, for example.
So there is a question from our radiologist that smaller nodules which are asymptomatic, is there a point in ablating that?
No. It's a very important issue. You will indicate ablation when you indicate surgery. You will ablate the nodules that you would operate. If the nodule is less than 2 centimeters, asymptomatic, benign, you will not operate these nodules, then you will not ablate. Maybe in the next years, with better understanding of the genetics and the behavior of the nodules, we can select nodules that will grow and prevent the growth with ablating precautions with these nodules. But nowadays, the indication is ablate if you will operate. If you not operate, do not ablate. That is a very important one, because we have a lot of.
I think this is a very important advice and indication that the patient who needs surgery,
yes,
they should be offered this option of non-surgical ablation of the nodule. Mm-hmm. So the patients who do not require surgery can have only the follow-up the way they are advised,
yes.
normally.
Mm-hmm. Exactly.
And of course, only the time will tell us to differentiate between those small nodules which are at high risk, and those nodules can be ablated in time to come once we have a very low cost genetic testing available for these nodules.
Yes. The importance is to give the patient the best treatment with a very good cost-benefit ratio. For example, here in Brazil, we have a study about the number of surgeries for benign nodules each year. If you convert 5% each year in the next 5 years of surgeries into ablation, you save, I put in dollars, $20 million in 5 years of costs in surgery. And there is another non-tangible costs that are not calculated. For example, how much costs for the patient and for the system to intake thyroid hormone for the rest of their life, or how much costs to perform an ultrasound every 4-6 months controlling these nodules. We can put this into the equation too and see if we transform the part of our surgical casuistic in ablation, you will benefit not only the patient, but the system, the health system with a whole effect.
Agree. Yes. Dr. Bhavin, if you have any questions.
Yeah. So how do we follow up this patient, sir? And
well, the standard follow-up is to perform the ultrasound 1 month, 3 months, 6 months, and 1 year after the procedure. And we have the dosage of the TSH and free T4 in the 2nd month, as we can do in surgery, for example. One very good advice I will give you: do not anyone perform an ultrasound 2 or 3 weeks after the procedure in these patients, because the aspect is terrible. If an ultrasonography that is not advised about it, oh, it's a cancer, it's a very, very ugly nodule. No, the aspect is very, very difficult even to measure before 1 month. In the 1st month, the aspect is very ugly too, but in the 3rd month, you can see all the tissues around contracting and the nodule shrinking and leaving the normal tissue border around the nodule. It's very beautiful to follow this.
okay. So what kind of cases you offer a stage ablation, stage microwave ablation? And what is the duration between 2 sessions of the ablation? Do you offer a stage ablation?
What kind of patients?
Yeah, you talked about some large nodule which is increased in size, such as 10 centimeter. You offer a stage ablation, multiple sessions you talked about.
We have to take care about the volume of the nodule. If the nodule, in my experience, is more than 50 cubic centimeters, you can warn the patient that maybe he will need a 2nd session. And the time of the session is between the 3rd and the 6th month, most of the cases after the 6th month of follow-up. We don't have here in Brazil any codes for the insurance companies to perform these procedures. Only 1 of 2 of the top insurance companies have this allowance and pay for the antenna. Most of the patients are paying for the antenna, or in some cases, in some states, I think in Rio de Janeiro, they could acquire this equipment for a public hospital, but this is the first one. We have a very little number of antennas acquired. We are trying to do this in our hospital. My hospital is not a totally public, not a private hospital. We attend the servers of the state of São Paulo, the retired ones, the active ones. We have a population of 1.2 million people and a lot of thyroid nodules too. My waiting list for benign nodules, it's almost 200 patients nowadays because of the pandemics. And then we are trying to establish with the directory and the administration of the state a quote of a number of antennas each month. But you need to show the administrators that you can reduce the costs comparing to a surgery from 30 to 50% using the ablation. You can show this to the administrators. You need to show the numbers, because it's expensive, it's $1,000 antenna, you'll not buy it. No, but you need to see the whole panorama to show them that you impact the costs over the time.
Is this antennas reusable or they are single use?
No, they are not reusable. Not the antenna, neither the connection of the antenna. There are two connections: the cooling connection with the plastic cables, and the cable that passes the energy from the generator through the tip of the antenna. They are not reusable. You can reuse this for teaching purpose, for example, as you use in the cadaver lab or the phantoms. You can use this, but even this, when you use 2 or 3 times, you can see that the performance will going down. Now, this is for a single use. But if the patient have 2, 3 nodules, you can use the same antenna in the same patient, at least 2 or 3 nodules, no problem.
Anyone else has any questions? Jignesh?
I know that is a lot of information. I can share my presentation with you. You send the PDF to Dana, then he can pass to you. And I have a lot of articles you can share. And you have my email, you have my contacts. You can contact me anytime. You will have next October our second training course here, including classes, more classes than this one, more specific classes. Training in a phantom that I designed specifically for this. It's very, very similar to a real neck, to train the position of the antenna, to ablate the nodules. There are nodules inside the phantom, and then to see real cases in close observation in surgical center. If you can, if you want to come to Brazil, it will be in the next October, I think 4th and 5th.
Thank you so much, Dr. Carlos. Yes, we would like to have the literature and presentation. I will mail you our requirements, and then we will communicate and get in touch more closer to what we did today. Thank you so much. Dana, Dana, you have some presentation, or are we confused?
Yes, sir. Yes, sir. Thank you very much. Thank you, Dr. Carlos, for that informative presentation and your share. I think it's we also learned a lot from your presentation, and as you already mentioned, that we will pass your presentation to HCG colleagues. And yes, of course, we have a very short presentation to show you about, just to give you a little background information about the microwave company, the Echo company, and our products. If that's okay, we are going to share the presentation. Just a second. Okay. Please just give me a second. Okay, so I'm guessing you can see my slides now. So just to give you a little background information about Echo Microwave Company, it was established in year 2000. We are a company manufacturer that dedicated to research and development, manufacturing and marketing activities of microwave and high frequency laser products. And our headquarters is located in Eastern China, Nanjing City, which is very close to Shanghai. And so far we have more than 500 employees operating in 32 independent offices and branches across the globe, including our colleague in the India, Mr. Satish. And our enterprise vision is to become #1 medical equipment manufacturer in China and top class in the world. So about the product part, you already know that microablation system consists of the generator and the consumables. Dr. Carlos also shared some images of our product in his slides. So here you can see the generator and the antenna we normally use for the thyroid ablation. Echo microwave generator is a CE and FDA approved 2.45 gigahertz microwave ablation, water cooling microwave ablation system. It's designed with a touchscreen interface, which is very easy to operate, and it comes with multiple safety measures to ensure the effectiveness and safety of the procedure. And other than that, unlike the other microwave equipment in the market, ecosystem, which is to make sure the energy delivery to the thyroid nodules is compromised compared with other organ ablations such as liver. And we also have another pulse ablation mode to minimize the risk of the pain during operation. And as for the antenna, we have the widest range of antennas for different applications. We have liver, lung, kidney antennas, and we also have special design thyroid series, which is in 16 and 17 gauge. Dr. Carlos already mentioned that. And the antennas are designed with user-friendly detachable design, which is more convenient for antenna puncturing before the ablation. And we also have a special designed antennas for MRI-guided procedures. As for the thyroid antenna I was mentioning, so it has the diameter of the antenna includes 16 gauge and 17 gauge, and it comes with 3.5 millimeter active tip to compromise the energy delivery. So when this antenna is used together with the special designed thyroid ablation mode, you don't need to worry about the energy delivery will be too strong, or if it might hurt the surrounding tissues. In our case, this doesn't happen because power delivery and the antenna tip is a special design for thyroid area, for delicate area like thyroid. And also this antenna can also be used for breast ablation as well. So as for echo microwave, we've started our international product marketing starting from 2015. And so far, we've been operating in more than 80 countries in the world with more than 65,000 ablation cases every year. And of course, this number is increasing year by year. And among this number, more than 40% belongs to thyroid ablation cases. And again, this number is also increasing every year. Nowadays, the thyroid ablation, thyroid minimally invasive awareness is increasing. So ablation cases are increasing as well. And the thyroid microablation reference centers that we have, this is just more end users on the list. So including Dr. Carlos Hospital, they've started the microablation since last year, November. And other than that, we also have many new doctors who are interested in this thyroid ablation, and that they are happy to know more about the technology as well. My apologies. A little network problem. Okay, yeah, so the evidence is microablation for solid benign nodules. We have many by different experts. Dr. Carlos and his team can also doing that. The project is going on, and we hope to have some more evidences in future to prove the efficacy and safety of this procedure. Next page, please. Thank you. So this one is for PTMC, papillary thyroid microcarcinoma. And also, Dr. Carlos also mentioned that microablation is suitable for hyperparathyroidism. So you can see there are some evidences as well. So that was about the evidence of the product. So now, as one of our core competence, Echo Microwave is well known for its academic support. Starting with the CCMA short for China conference, microablation, it is an excellent academic platform since 2015, which was the first year that it was held here in China towards domestic doctors. But starting from 2016, this conference became an international event and attracted more than 500 delegates worldwide. So we had many doctors, interventional radiologists from India as well, that participated in this program in 2016, 2017, and they also shared their research results on this meeting. So on this platform, we also cooperated with the Society of Interventional Oncology to hold joint sessions and training centers. So this has been a very good ablation-themed communication and multi-party cooperation platform for doctors in the related field. So other than that, we also try to establish related training centers, cooperations with the related associations. As you can see that we have been closely working together with Interventional Society of the Indian Society of Vascular and Interventional Radiology, ISVIR, and we also cooperate with many different associations in other countries as well. And we hope to cooperate with more surgical associations and endocrinologists in the future as well. And as part of the academic aspect of our service, we also established some training centers in the overseas, including the training center in Turkey and Germany and Egypt. And we also, in cooperation with Dr. Carlos Hospital, and the agreement is about to be signed, but Dr. Carlos and Dr. Fernando, they already helped us with the training programs. And as he mentioned, they are planning the second training program in October 3rd to 5th in the Brazil. So the doctors from surgical department, they can join this training program to have more systematic information about the thyroid ablation. So these are the training programs that we had in the past 1 year. So successfully held more than 10 CCMA series training programs outside China because of the COVID. Before COVID, we would invite many doctors to come to China for the training, but during COVID, it's been a little difficult. But with the help of the experts in other countries, we are being able to organize this kind of training programs in many different places. So we hope to have this kind of training program in India as well, with your help, of course. Next page, please. Yeah, so here are some pictures from the training programs that we had in the past. This was the training program in Italy. In the next page, we have another training program that was held in Turkey with the Dr. Bulan Dr. Carlos also mentioned him. And the next page is another training program that was held in Jordan. We invited Dr. Bullen to Jordan to provide at-site guidance to the doctors in the Jordan. And now the doctors in Jordan, they're starting their own cases. And just last month, we also had the training program in Brazil in July 12th to 13th at Dr. Carlos and Dr. Fernando's center. And it was also another very successful event. And the doctors from Ecuador, they are planning to start their own cases in Ecuador as well. Next page, please. And other than the offline training programs, we also organize a lot of CCMA series webinars on thyroid ablation. You can see this was the some programs that we had. For last program, we also invited Dr. Carlos and Dr. Fernando to share their knowledge from surgical aspect. So we have many different webinars that are themed on microablation. In future, we would also hope that HCG doctors, experts can be part of these programs, of course. Thank you. Next page. Yeah, these are the academic conferences that we are participating in. These were the programs that we participated in the first half of 2022, interventional radiology conferences, or surgical related or thyroid related conferences. We are trying to be there to increase the awareness of the thyroid ablation, and of course to promote the product as well. And in the next year, in the next half year of 2022, we also have more plans for more conferences to expose, to increase the exposure of the technology and the product. Next page, please. Thank you. Yeah, these are the plan for the next half of 2022. Next page, please. Thank you. Thank you. That's all. I believe there's 2 different conferences in India about thyroid ablation, about thyroid treatment. So we will be there as well. So if my colleagues visit India, I'm sure they will visit you in HCG. Thank you very much.
Thank you, Dana. That was a very comprehensive introduction of your machine and your academic activities which you support. We look forward to more interactions, and would like your representative to meet us at our center so that we can think about starting at our place. Thank you.
Thank you very much, sir. Thank you. Our local representatives and our local colleagues will definitely try to go visit you as soon as possible to see how can we help you to start the program. Thank you.
Bhavin to Carlos, thank you.
So, thank you, Dr. Carlos, for the extensive presentation of this newer technique in such a palatable form. Means you explain the technique in very detail, so we know about the patient selection as well as procedure. Thank you very much.
Thank you.